Hi, I'm Dr. Craig Walker. I'm an interventional cardiologist in Houma, Louisiana. I'm also a professor of medicine and cardiology at Tulane Medical School and Louisiana State University Medical School. I'm also the editor of Vascular Disease Management. I'm an interventional cardiologist, but I have massive interest in the peripheral vascular field. Limb salvage is one of my primary areas of interest. I live in Houma, Louisiana, which is on the very southern part of Louisiana, very close to the Gulf of Mexico. Behind me, here's the Intracoastal Canal, which is a major canal for commerce running between Florida and Texas, and it runs right behind my office where we're filming this today. I moved back to Houma in 1983 to start the Cardiovascular Institute of the South. I moved back to Houma from Harvard because this was my hometown and my family was living here. I look forward to meeting with all of you.
Hi, my name is Dimitri Kuchel. I'm head of radiology and chief of interventional radiology in University Medical Center Ljubljana. Welcome to Icarus.
Hello again. This is Jan Skowronski, Birmingham, Alabama. I am delighted that we can move to the next session. If we could have the general Icarus screen. Okay, perfect. So we are moving to the next session, and I would really like to introduce the next session chairman. Craig Walker, everyone in the world knows Craig Walker for what he has done. And I think on a human level, it's a very interesting story. He's from Houma, Louisiana, which is a small town south of New Orleans. He went to train in the best institutions in the States, and he decided to go back where he was born and raised. And since he's opened his practice in there, he built this incredible cardiovascular powerhouse. And he is a fantastic innovator in terms of new medical devices, in terms of research, but also in terms of education. He runs a big New Horizons program out of Louisiana. And my personal experience is that when I was a fellow and I really wanted to do peripheral interventions, he ran courses for fellows for several days. So I signed up for a course. And I flew to New Orleans, and I thought that after the cases, I would be spending my time on Bourbon Street in New Orleans. And in fact, that wasn't the case, because Houma is about 70 miles away, and it's kind of a different country. It's not New Orleans. So we are very grateful you're with us, Craig, and the floor is yours. Thank you so much.
Thank you, Jan. I'm very pleased to be here with you. I've just recently finished reading the Michener's book, Poland, and it is one extra little thing making me enjoy this. We have a great panel today, Doctors Miner, Kuhelj, Braun, and of course, you. And with that, we're a little behind now, so if we could pull up my talk, radial access for treating brachiocephalic, subclavian, and iliac occlusive disease. So, Jan, I heard some of your comments earlier while we're getting this up. I was trained in an era where I had to do brachial cut downs and other things. I think radial is more than just being able to not have to cut down to a brachial. I think it's a safer approach. When we have to cut down, there are potential infection risks. Of course, a brachial complication is a big issue. As long as we have a patent arch at the hand, and we prove that, I think radial becomes a better way of approaching many cases of peripheral vascular disease, in particular subclavian, iliac, inferior mesenteric, and those sorts of areas. Now, to be fair, for a celiac and superior mesenteric, I prefer a femoral approach because I can get a true lateral projection. But with that, I'm going to start with my talk on where I've used radial access and where I think it's a game changer. And so I'm going to just start with two cases. So radial access, when I perform this, I actually put an O2 monitor on the patient's thumb. And that gives me a good idea whether or not there's any ongoing ischemia. So this is a patient who presented in the past who's a 45-year-old man. And he was sent for coronary artery bypass surgery. He had critical left main, severe multivessel coronary artery disease, which we knew about. But we also knew from the hospital, they had tried to cath this patient from each radial and were unsuccessful. They could not cross a critical brachiocephalic lesion or a critical left subclavian lesion. They ultimately performed the case from the leg, and they found critical bilateral iliac disease, not shown so well here, but it was actually critical. They did cross it, and the patient also had renal artery stenosis. Now, of importance, imagine this man needs bypass surgery. Therefore, circulation to the brain on the right is not so good because both the vertebral and the carotid are distal to this very critical brachiocephalic lesion. On the left common carotid is totally occluded. We know that. And on the left, the vertebral is getting its flow via high-grade subclavian lesion. So this man with surgery, we would not be able to monitor pressure in either arm or either leg. Blood flow to the brain would be very poor. And the surgeons would not be able to use either internal mammary artery in this patient with a very calcified arch. So this patient, upon arrival, developed diaphoresis and dyspnea, and the nurse called me frantic, said the EKG is terrible and the patient's blood pressure is only 50. I asked that she give nitroglycerin, and before she could say anything else, she said, I will not, the pressure is 50, and she hung up on me. I finished my case, I was in the lab, and I ran there, gave nitroglycerin, and the patient's pain was out. The nurse had not stayed on the phone long enough to understand that the pressure she was measuring was incorrect. Now, what did we find? Well, I approached this patient first from the right radial, and we can see this patient had a very high-grade right radial. In fact, the 035 glide wire was totally occlusive. There was a 140 millimeter gradient across this brachiocephalic. This was ballooned and stented with a 12 millimeter stent. And of course, there was no residual gradient. Now we've restored flow to the brain via this vertebral and this carotid. Now we can measure pressure in the right arm. Now the right internal mammary can be used as a conduit. Next, we turned our attention to the left side. Again, a very high-grade stenosis. This is after I dotted through this with a catheter, but it was very tight. It was an 80 millimeter gradient here. This was treated with a balloon and a stent with no residual gradient. Now the patient has vertebral flow. So 3 of the 4 vessels now going to the brain are working properly. The internal mammary can be used as a conduit. And in fact, the very next day, this patient had an off-pump Lima to the LAD, Rima to the right, with plans for me to come in later and perform circumflex left main stenting so that he could have total arterial conduits. Another patient, a 51-year-old man, severe coronary disease, needs bypass. Upon asking him, he has not just got claudication, but he's impotent. The surgeon wanted to operate right away, but I said, let's at least just check CT because it could affect our ability to harvest veins from the legs and other issues. Now, this is a case I actually ultimately did live for TCT. The CT shows total occlusion of the right common iliac with reconstitution of the femoral. On the left, we can see there is total occlusion of the left external iliac. Take my word for it, there's going to be a critical internal iliac lesion. I'll show you that. But the lateral CT tells the whole picture here. What's filling the legs? We can see these branches coming up on the anterior wall. These are the collateral pathways of Winslow arising from the internal mammary artery, and they're supplying the legs. So I did this case. In this case, I actually come from a brachial approach, but I asked you to follow the internal mammary artery down from the chest, and you can see it was filling the leg just as the CT showed. Distal aortogram showed no filling of the leg whatsoever. Now, what happens if this internal mammary is taken down in surgery for bypass? And what happens to the patient long term if the internal mammary is not used in a 45-year-old man for bypass? Outcomes aren't as good. In addition, leg wounds may not heal. So what did we do? This case was done live in 20 minutes, and we can see we first crossed the totally occluded right from above. I always like to cross these from above. I think your chances for true luminal crossing are much better. Once we crossed and ballooned, we put a sheath up from that side. Now we turned our attention to the left side. And here you can see the very high-grade internal iliac lesion at its origin. You see the totally occluded external. We've crossed it with a wire. Now, this man was only 51 years old and impotent. What happened to my slides? Here we go. So we treated the internal iliac as well as the external. And here we can see the final result. Nice flow, all done in 20 minutes. And this man had a very uneventful coronary artery bypass. Now, this man was very happy. Well, he was very, very happy that he no longer had claudication. But what he was most excited about was he was no longer impotent because he had flow restored. So alternate access allows patients to have procedures in a much more comfortable manner. It allows us to cross lesions sometimes we otherwise could not cross. I think it's safe, and I think all of us must learn every form of access available if we're to achieve best outcomes. Any questions?
This is Jan very briefly. I have to admit that I'm relieved by you showing these cases, because I would say we do things identically where I am. So if I do things almost in an identical fashion to Craig Walker, I feel relieved. Thank you.
Any other questions? If not, let's ask Dr. Braun to present to us on central vein stenting. Dr. Braun.
Hello, I'm Dr. Krzysztof Braun from Warsaw, Poland. Let me show you places where I work. I hope it will be interesting for you. This is cath lab in my hospital where I treat vessels every day. And the word vessel is quite important here. And that is another workshop of mine where I build vessel. This is rowing vessel. I practice rowing on Vistula River in the center of Warsaw. And now I'm building my own single scull. I would like to tell you several things about central vein stenting. In the world where I work, we have strong cooperation with 8 dialysis centers, and there's where we have our patients with central veins occluded or narrowed from. Typical causes of central vein stenosis or occlusion are catheters or wires. That's quite obvious. And the main indication for recanalization is symptomatic stenosis or occlusion. And in case we have AV fistula for dialysis, on the ipsilateral limb, edema is often very debilitating, very painful. Fistula becomes aneurysmatic or thrombosed. That's typical appearance of the fistula, with aneurysms, collaterals on the chest wall. What can we do? We've got the same possibilities as in arterial vascular bed, PTA with plain balloon, ultra high pressure balloon, drug-eluting balloon, and stenting with bare metal stents or covered one. Let me show you our one case of our ward, 50-year-old female.
who came to us 3 years ago, and that I will come later, with very long bleeding from the fistula. And what we see here is quite obvious. After permanent catheter that was inserted through the right jugular vein, she has tight narrowing. In such a case, the procedure is quite straightforward. You have to navigate the Terumo guide wire and then make PTA. That's what we did with Admiral Stream 10/40, but although flow is quite fast, you can anyway see some collaterals still present. So the pressure in the fistula did not decrease enough. In such case, we always go for covered stent, because bare metal stents don't do well in such cases. They narrow quite quickly in several months. So we implanted fluency 13.5/40, and now it looks quite well. Oh, sorry. Yeah, that's how it looked. We can't see any collaterals, so there is no hypertension in fistula. After 2 years, all the symptoms of hypertension in the right upper limb reoccurred, and once more we inserted 6 French sheath in the fistula, and what we saw is occlusion of stent. We don't exactly know whether whole stent is occluded or only proximal part. We tried to negotiate guide wire from the fistula, but we failed. So we made closer view. Yeah, the occlusion is complete, and then we inserted long sheath in femoral vein, and the guide wire passed through the occlusion quite easily. But look here, the balloon 6/40 was inflated, but it jumped forward, so we had to withdraw it and then withdraw the sheath, and then slowly inflated balloon behind the stenosis, and then putting traction on it, not to let it go forward, we inflated the balloon. Yeah, that's the stenosis. The most important factor here is to have good support from long sheath inserted through the femoral vein. And after PTA, the result was once more quite good, but it's a little bit more stenosed than it used to be after the first procedure. But time flies, and in March this year the lady appeared once more in our ward with the same symptoms, even bigger edema of the upper limb. And what we saw is once more occlusion of the stent. This time we went quickly to the femoral vein, and as you see, there is quite short occlusion of the proximal part of the stent. And although we had good support and we tried with soft wires like Terumosoft and then hard ones, we did not succeed to cross. Then I took Astato from Asahi, 0.14, and I managed to go through the stent, but I did not manage to re-enter the vein. And in fact we failed this time. But what is important in that procedure is that going also with sharp wire like Astato through the occlusion and then through mediastinum is quite safe, because the pressure in the veins of the chest is very low. So even if you puncture through the vein wall, there is no risk of hematoma of the mediastinum. And that's final picture with a permanent catheter inserted through the left jugular vein. And the question is, what could we do better? Probably drug-eluting balloon on the second procedure, or stent. And probably if the patient would be referred to us at the very beginning of hypertension in fistula, maybe we could succeed. Thank you very much.
Thank you. That is a great presentation. I have a couple questions for you. One, do you have in Europe a drug-coated balloon that would be big enough for this? We don't in the US. The biggest drug-coated balloon that we have is 7 millimeters. And secondly, in the past, we did use balloon expandable stents. In the very earliest part of the Palmas stent, one of the compassionate uses that we had were in patients who had cancer of the upper lobes of the lung, so-called Pankos tumors, who developed superior vena cava syndrome. And there was dramatic relief when we were able to open the superior vena cava in those patients, dramatic pain relief. Of course, it did not affect prognosis in these cancers, but it did tremendously relieve symptoms. Do you in Europe have a drug-coated balloon that would be big enough to treat this? And secondly, I do have one final suggestion. In a case like this of true in-stent restenosis, where it's difficult to cross, often a laser catheter will cross. You're inside the stent, and as you push, the stent stops you from going extravascular. And we've had many cases where there was wires simply would not cross, where we were able to run a catheter, particularly the turbo power, which turns, and it would get us all the way to the end of the stent. We would stop before exiting the stent and then lead with a wire at that point. Did you have access to that, or have you ever used that technique?
I have heard about that technique, but we don't have such possibilities in our ward. And the first question was about size of the drug-eluting balloon. Right. The biggest one is 10 millimeters, so it would be enough, probably.
Sure. In the US, 7 is the biggest we have.
Very common. The size of the balloon, Dmitry Kuchel from Ljubljana. If there is occlusion or tight stenosis, we treat it with a relatively small balloon. and then we post-dilate with the bigger one. At the beginning, you deliver drug, and then you dilate to the size you want.
Okay.
This is Jan Skowronski. I think I have to agree with Dr. Kuchel. You know, it's really about drug transfer into the vessel wall rather than the size. So we probably would keep the balloon inflated for a minute or a minute and a half. You have enough drug transfer, even if we don't have adequate sizes in the US, and then we would just post-dilate or use another stent. And I couldn't agree more with Craig Walker. Definitely laser in these cases. And I would say that that's usually very successful, not a lot of restenosis. I agree. Thank you.
One comment, Rob Miner in Montana. Is it the right stent? You know, this is a stent that has some metal extending beyond the covered portion. And we found in the past that Viabond sometimes is a better choice for either a restenotic case or primary therapy, because we don't have that edge restenosis problem like we do with the fluency.
Yeah, that's a problem, but with solve it. Now we have Cavera stent, which doesn't have any struts protruding beyond the covered portion of stent.
This is Jan Skowronski. I haven't done it yet, but I think I personally would be tempted to use Boston Scientific Alluvia stent in these cases with proper pre-dilation, adequate pre-dilation. But again, the problem is that the biggest one is 7 millimeters. But that's perhaps an option if the vein is not too big. Thank you.
Okay, well, if no other questions, first, Rob, that's beautiful background that you have over there in Montana. I really like all those flowers. That's very nice. But let's move on to our next speaker. We're going to ask Dr. Jaffer Gulzar to show us an SFA atherectomy case. Jaffer, are you here? Oh, wait, no, my mistake. Please forgive me. I jumped on my, no, our next speaker is going to be Dr. Stepniewski, who's going to speak to us of endovascular management of acute pulmonary embolus. Forgive me, I jumped on my program.
Hello, this is Jakub Stępniewski from Krakow, Poland. I'm an interventional cardiologist specializing in the treatment, interventional treatment of acute pulmonary embolism. Welcome to Icarus.
Okay, yes, good afternoon and good morning. Thank you for this invitation and your interest in the endovascular methods for the treatment of acute pulmonary embolism. I am an interventional cardiologist from Krakow, Poland. I represent the team for pulmonary circulation disorders run by Professor Grzegorz Kopeć. We are the referral center for various types of pulmonary circulation diseases such as pulmonary hypertension, chronic pulmonary embolism, and acute pulmonary embolism. The acute pulmonary embolism remains one of the most common causes of acute cardiovascular morbidity and mortality after MI and stroke. And as trends show, the incidence continues to rise throughout the recent years, posing the true challenge for today's cardiology. Endovascular methods fall into the category of reperfusion treatments of acute PE, next to systemic thrombolysis and surgical embolectomy. And their aim is to restore the patency of pulmonary arches blocked mainly by thromboembolic materials. And according to the contemporary cardiology guidelines, they can be used for the treatment of most severely ill APE patients who have hemodynamic instability, right ventricular dysfunction, and injury, who are not candidates for systemic lysis or surgical embolectomy. And this translates into about 10 to 15% of applications of these methods in all APE patients. In order to support the decisions which patients should require reperfusion and which method is the most optimal, the guidelines recommend to formulate the teams of PE specialists, the so-called pulmonary embolism response teams, who can quickly evaluate the patient and make a decision with regard to the most optimal treatment. These PERTs may be composed of interventional cardiologists, angiologists, or radiologists, very often cardiac surgeons and intensivists. And these slides are presented the structure and modes of operation and the therapeutic algorithm that we have developed and adapted and used for the daily basis in our PERT and our hospital. We have also developed a mobile application to improve the communication between the PERT members. We have conducted more than 100 consultations, acute consultations since the beginning of our program, and the majority of the patients did not require reperfusion, and they were safely and efficiently treated with anticoagulation. But for the remaining 30%, 20% were treated with endovascular, with a endovascular method. In our hospital, we have adapted two different strategies for the selection of treatment, of endovascular treatment. The first one is the catheter-directed local thrombolysis, and for this purpose we use the Icarusconference system. This is a unique device that is composed of infusion catheters, which have installed inside the central lumen an ultrasonic core, which enables or allows for delivery of ultrasonic energy into the clot, allowing for enhancing the lysis and allowing for lowering the dosage, the electric dosage. And for patients,
na kablu, a nie na Wi-Fi. Po Wi-Fi, no to w ogóle.
We use an aspiration thrombectomy device, an Indigo system by Penumbra.
Helenka właśnie powiedziała, że miała fazę, żeby sobie pośpiewać, ale się powstrzymała na szczęście.
In our hospital, the most experience we have with the ecosystem, I'd like to share with you.
Bo ktoś tam nie wyciszył.
Share with you the history of one of our cases. This was a 36-year-old man, previously healthy. He suffered from an acute high-risk PE complicated with cardiogenic shock, and he was initially treated with full-dose systemic intravenous thrombolysis in a regional hospital, but only a modest improvement had been achieved. And due to persistent dyspnea and right ventricular dysfunction, he was referred to our hospital, to our center for endovascular treatment. At presentation, he was in pretty bad shape. He had severe dyspnea at rest, tachycardia, low blood pressure, and low oxygen saturation. And the cardiac necrotic markers were highly elevated. NGOCT shows nice resolution or reduction of the saddle thrombus after the intravenous thrombolysis, but still massive clots are persist within the central location of both right and left pulmonary arteries, and the right ventricle is severely dilated, threatening with right ventricular failure and cardiac arrest. So within the PERT, we decided to use the ECHOS system, so ultrasound-assisted catheter-directed low-dose thrombolysis, due to the fact of failed thrombolysis and deemed high operational risk for surgical embolectomy, decided by or judged by the surgeon. We used the regular right femoral vein access with a dual lumen 12 French introducer. First, we selected the lower lobe with the use of a multi-purpose guiding catheter. We used the lower lobe right pulmonary artery, and then along the along the guide wire, we inserted the infusion catheter of the ECAS system, and placed it so that the treatment zone, which is between these two black spots, was in the main body or within the body of the thrombus. In the next step, we introduced this ultrasonic core into the infusion catheter and started the ultrasound enhanced alteplase infusion at the rate of 1 milligram for the right pulmonary artery. We repeated the steps for the left pulmonary artery, and started the infusion for the left pulmonary artery at the same rate. At this moment, the patient was transferred to intensive cardiac care unit, and the alteplase infusion with these two endovascular devices. He was, and the alteplase infusions were continued for 5 hours at the rate of 5 milligrams, with a total dose of alteplase of 10 milligrams. After that, we have reevaluated the patient and saw that the patient has the dyspnea of the patient resolved. His tachycardia started to reduce and saturation improved. Also, hemodynamic parameters improved significantly, very nicely. Pulmonary artery decreased, so mean pulmonary artery decreased to 31, and his cardiac index improved. So based on these parameters, we decided not to extend the treatment. With the alteplase, we continued anticoagulation in this patient, first as an intravenous heparin and then oral anticoagulant. The post-treatment angio-CT showed nice clearance of the clots in here, regaining the patency, and further reduction of the right ventricular dimensions, the diameter. Within the further hospitalization, we observed the improvement of clinical, biochemical, and echo status. There were no bleeding or procedural complication occurred. After 5 days, he was discharged home, and he's on DOACs for VT prophylaxis. He was at the 6-month follow-up visit. He has no exercise limitation and no recurrent PE. And with this visual invitation to Krakow, I thank you for your attention.
Thank you. That was an excellent presentation. Any comments from any of our panel or questions? If not, I will just say that this is certainly represents a huge change.
So this is Jan Skowronski. I would like to say a word, if I may.
Sure.
But let's have a panel view. I mean, obviously great case, but on a bigger scale, I think we do 2 or 3 times more pulmonary embolus work that we literally did 2.5 years ago. I think indications are expanding, and sometimes US is kind of slow to approve devices. But in this particular case, we do a lot of echos. Sometimes for subtle pulmonary emboli, we use Inari device. And I'm personally very hopeful that a new company, Thrombolex, that hopefully will be coming to the market within a year or 2. It also looks very promising. I think the biggest challenge we have, we go by clinical scenario, how the patient feels, saturation, vital signs, hemodynamic compromise, that's obvious. But we go mostly by RV-LV ratio on the CAT scan. And it's just close to impossible to teach radiologists to report this in every single case of a pulmonary embolus. Like every case I have to go down to radiology department and talk to a radiologist about it. So that's our big challenge. But definitely now the cases are routine. Thank you.
Yes. One comment is not only the RV-LV ratio, but also this statement massive. There's always a massive pulmonary embolism stated by the radiologist. No matter the clinical status of the patient is, it's always a massive pulmonary embolism.
So typically, I don't know, Craig and Rob, what you would do, but typical case, someone comes and is kind of sick, but it's not like critically sick. But we know that in clinical studies for pulmonary embolism, they usually only look for 6 months outcome or maybe a year outcome. And then patients who were treated with anticoagulation or even no, you see them 2, 3, 4 years, 4 years later, dilated RV, pulmonary pressures in the 50s and 60s. They cannot even do their shopping. So we are definitely much more aggressive in treating it. So if we have kind of a borderline patient, we go to the radiology department, we look at the CAT scan, we look at the RV-LV ratio, and if the pulmonary embolus is central, we would typically use mechanical thrombectomy, Inari device. If it's a little bit more peripheral, I always go for ECOS at this time. Thank you. Craig, back to you.
I agree with what you've just said. Right now the biggest fight is with pulmonologists because, as you've said, the data's only out to 6 months. We've developed a nice working relationship with them, and no one argues about the really massive pulmonary embolus. The question is submassive, and what do we do? And obviously there we have to weigh the risks. And I don't think we have enough long-term data to really say one therapy is better than the other. But I suspect as we get better and better and have fewer and fewer complications with some of these mechanical devices, we may see indications change. Like everything else in intervention, right? It depends on how much risk there is. Yes. Rob, do you have a comment? I see you moving your lips. Are you commenting? You're on mute if you are.
Yeah.
You need to
I was just saying, Montana, with the younger patients under 60 who have bilateral pulmonary emboli, we've taken a more aggressive approach, even if they don't have signs of RV failure, of treating them with ECOS and thrombolysing them. And this is a low-risk group with thrombolytics, and I think they have a lot longer life to see if we treat them aggressively.
Okay.
Couldn't
With that
agree
being
more.
said, if there are no other questions, why don't we move on to our next lecture on covered or uncovered self-expandable stents for AV fistula treatment. We'll ask Dr. Magdalena Mierzwinska.
Yes, thank you. Hello to everyone. Welcome from Przemyśl, from Southeast Poland. So, covered or uncovered? The answer is on this slide. The cover stents only because they have the lowest rate of the reinterventions and the best primary patency after 12 months. When to use covered stents? They are especially indicated for the venous outflow stenosis, which is the second of the most frequent cause of AV fistula dysfunction. We have also relatively off-label use. There are pseudoaneurysm, central vein thrombosis, rupture, and cubital fossa placement. I mean Juxtaanastomotic stenosis. Contraindications, which are also relative. It's if you can avoid stent placement in puncture site. Of course, you shouldn't use it in immature fistula, but of course you can help to mature fistula, putting the stent into occlusion in AV anastomosis. It's relative also because the full expansion of PTA balloon is not necessary. Of course, if you put a covered stent covering the side branch, you can prevent future procedures. You have to remember about that. It is the same when you put it in the cephalic arch. Of course, hypersensitivity for nickel and titanium is not recommended as putting the stent in. Some technical data, qualification, of course, clinical examination first, extended bleeding, rippling of the fistula, thrombosis in the distal part of fistula. You have to confirm it in the ultrasound, and you have to exclude thrombosis of the deep veins and measure vessel for future sizing. Two groups of patients with dysfunctional but still patent access, and with thrombosed fistula, which need another procedure to recanalize access. I prefer Covarosat expanding stent because it's dedicated for the fistulas. It has suitable flexibility, radial force, a right range of diameters, and 2 configurations, which is very important to fit AV vessels. Tips&Tricks for access. System works with 8 French sheath, besides 3 biggest ones which need net French sheath. Rather use bright tip sheath for your comfort. Of course, I always cannulate the fistula under ultrasound control because you should puncture as far as possible from venous outcome, as close as possible to skin, and beside narrow and tortuous part of fistula, because it gives you comfort of working and after the procedure safe closure. If you are in an open surgical thrombectomy, you can use open access, but you have to remember about preventing the rethrombosis. Of course, using a heparin. Tips&Tricks in crossing. System is compatible with 0.35 wire, but in the case of total occlusion, I prefer using 0.18 wire. For severe stenosis, it's better to use hydrophile wire, which is changing after crossing the occlusion. In cephalic arch, you can put the wire retrograde in brachial vein, which give you more precise landing zone, or Anterograde, which is less precise but more safety in case of disaggregation of the stent. You should rather avoid use of stiff wires. Preparing and sizing, predilatation is needed. Don't oversize. Diameter of the stent. Here is the oversizing, about 1 millimeter. If there is a difference between inflow and outflow diameter, use inflow diameter to choose the stent. Length, you have to extend it at least 5 millimeters distally and 10 millimeters proximally. In cephalic arch, it is important to put stent not shorter than 6 centimeters. Expanding stent, of course, you should advance system and pull it past the lesion. Then you should pull it back. You have 3-axle system with 2 speed controllers for slower speed at the beginning. Remember, it's very important that this stent likes to migrate distally and has foreshouldering during the deployment. You can't reposition the stent. Besides short pull after maximum 1 centimeter expanding. You can't retract stent into the system. And this is the technical data. And last but not least, I finished the procedure with new hemostasis suture, which gives usually complete bleeding control. And some examples: Brachiobasilic fistula stenosis with venous outcome. We have Anterograde access, slightly by the vein, dilatation, control angiography, stent, covered stent flared one. And this is the final angiography. The next one, stenosis of venous anastomosis in a graft, Anterograde access as well. Here is the stenosis after the predilatation and final effect. Juxtaanastomotic total occlusion. It was an acute procedure, retrograde access, first angiography, crossing into the artery, brachial artery, predilatation, and final effect. And the next one, stenosis of the cephalic arch, very often Anterograde access, first angiography, predilatation, control, and after the stent placement. Brachiobasilic right fistula, the stenosis of subcutaneous transposition side. This lady has a very rare interventions, and I decided to put the Covera stent in it. It's after the pre-dilatation with a high pressure balloon, and the final effect with a residual stenosis less than 30%. It has a good effect because it works 24 months. I have seen this lady 2 weeks ago, and it goes on without the intervention. Thank you.
Okay, great. Very nice presentation.
Craig, this is Jan. Beautiful case. So a question to panelists, if I may, and I would like to run one quiz in a second. But my question is, well, do you guys use drug-coated balloons for these indications? Do you think they work there? Magda?
Yes, we use drug-coated balloons, but especially in venous outcome, for me, covered stents are better. They have lower, they delayed the reintervention, sorry, most.
Okay.
Better.
So, Craig, if you give me the honor of running just one quiz, because we talked a lot about alternative access, especially for mesenterics, renals, iliac artery. So let's just run a quiz number 8. I hope you're okay, Craig, with it.
Sure.
So here is the question. You plan to treat subtotally occluded superior mesenteric celiac trunk in a highly symptomatic patient with a weight loss. What's your preferred access? I would like people to vote if possible.
Can you come on screen, please?
I know it's a little tough to switch to the quiz. So maybe if we don't have any answers at the moment, maybe Craig and Magda and Jakub and Rob Miner can comment.
Okay, I'll start with that. You know, I think sometimes it's easier to cross from above, but I prefer treating the celiac and the SMA from below. And I'll tell you why. I think it's crucial to be able to obtain a true lateral position, to ideally see where the vessel originates from the aorta. And I have problems sometimes doing that from above. I think that's a big issue to me. Now, when I'm treating the inferior mesenteric, and I now have 15 cases that I've done where the only patent vessel to the gut was the inferior mesenteric, that vessel I think we have to treat from above. The bend is so great that it's very difficult to treat in that way. I guess my vote didn't get in there, but I like a femoral approach from this. And I've found, and I've treated many of these, and of course have written case reports and have published on mesenteric treatment. I have treated many hundreds of these over the years, and I have found, I've tried both routes. I've found that being able to clearly identify the origin is very, very helpful. And when we get a wire far enough out, I think they're very easily done, just using a standard renal double curve working in a true lateral position.
Rob Miner here. Maybe I'll comment next. In the COVID era, I think it's important for us to expand our use of outpatient therapies for all of our patients. We are a radial first lab and do virtually all of our PCI cases radially as a patient when alive. For indoor, we're trying to do all of our cases radially as well, and there are challenges when you have to reach far into the SFA. Personally, I prefer all mesenteric and celiac disease radially just because of the coaxial approach you get from above and the kind of the no-touch approach you have to the ostium. We like to go 60-degree RA when we're going right radial. That often gives you enough lateral projection to place your stents properly. But I guess I'd like to get Jan and Craig's comment on our need to move more to outpatient therapies here, as patients really don't want to be hospitalized, and there is a real need to keep people out of the inpatient units.
Yeah, I do 90% of my patients outpatient as well. And I simply close the femoral on those patients. I use a suture-mediated closure or an external plug when I'm doing those cases. And we've gotten those patients home the same day. We do most of our peripheral work now radial. We have a huge experience with radial. I just really think it's crucial to see the ostium of these gut vessels. They often vary a little bit. We have to turn, but for me, precise stent placement trumps other things on the superior mesenteric and celiac. That's why I go that route. But I'm a huge radial user. I like radial approach.
This is Jan Skowronski. I would say we do majority of the work radially, including superior mesenteric arteries. And I personally, I don't recall doing an SMA or celiac trunk case through femoral in the last probably 2, 3, 4 years or so. We go 75 up to 80 degrees. We keep hands very close to patient's body, and we cannot get 90%, but 90 degrees, but we can get about 75. Somehow it works for us. And I personally see this a little bit of a discrepancy, because when you look at coronary work, Europe has adopted radial approach much earlier than the United States. But for the peripheral work, it appears that many more Americans do radial-based work than Europe. And what do you think, Magda and Jakub? Well, what's the case there? Why is that so?
So in my unit, we use the brachial approach. And your comment about our position, about the patient, is the best for that.
And I'm not familiar with this this particular procedure, but truly for cardiovascular PCIs and coronary interventions, we predominantly use radial approach. Femoral approach is very, very rare. But I'm not sure if the surgeons or angiologists they prefer. I think they still prefer the femoral access. Maybe it's because that in Polish system there is no such a rush to discharge patients early, and we, although it's possible and doable, we even after PCIs, patients rarely are discharged the same day or the next day. It's usually probably the funding matter also.
So this is Jan. I think we'll be concluding the session, but before Craig has his comments and closes it, I can tell you that the typical scenario, especially in post-COVID or still by all means COVID, the number of cases in Alabama is growing. The typical scenario for a patient with any type of peripheral arterial disease, he or she comes at 7 o'clock or 7 o'clock in the morning, gets seen by one nurse. We take the patient to the cath lab. We do a radial approach intervention. The patient is preloaded with Plavix 7 days before, so you have double antiplatelet therapy on board already, and the patient is essentially discharged by 1 o'clock or so, if this is first case of the day. Thank you.
Sure. In wrapping up the session, I would say that I use radial a lot. I use pedal approach a lot. But frankly, I think we have to use all approaches. There are some cases where radial does not give enough support, densely calcified lesions that are very long. Sometimes where we want to use various devices that otherwise may not reach. And so there are many criteria here, but access and access site control are crucial for all interventions. I think this is very important. And I think we must be familiar with every access as it comes out. We certainly fought big battles in the past in America to be able to allow people to do pedal approach or popliteal approach. When we first reported that, these were all new access sites, but they really did change our ability to cross, our ability to deliver therapy, our ability to end up with good and durable outcomes. And I think all of us have to learn the various forms of access. We also have to learn the potential risks of those access sites. We can't willy-nilly use a radio because if there's poor hand arch blood flow and we obstruct that radial artery, then we have a huge problem on our hands, and that becomes a big issue. So I think we really do have to watch this carefully. We have found that in doing radial cases, putting in an oxygen probe on the thumb is very helpful, letting us know if there are any issues. Of course, we do an Allen test ahead of time. But even with that, we still monitor this during the case. And I think this is very, very useful, particularly in very long cases. But that being said, I think approach is crucial. It's going to affect crossing, subsequent complications, how the patient does long-term. We have to get good at all of them. With that, I know we've run a little bit over on this session, but unless there are any objections, I think we should close this session and allow our next group to start. Is that okay? Good.
Thank you.
Been a real pleasure being here.
Thank you. So Jarek and Grzegorz, back to you.